Yes, now our next presenter is Dr. Devesh Kumawat. He will discuss in other retinal diseases like ROP, ARMD and artificial intelligence. He is MBBS MD from AIMS, DNB, AIOC, FAICO, FRCS ophthalmology in both parts. Senior residency in RPC AIMS, Delhi. Now is ex-assistant professor is AIMS Rishikesh, assistant professor of LHMC, and has with him with index publication of 70. Now, thank you. Now start with your presentation, Dr. Kumawat.
Excuse me, it's not getting displayed. Excuse me, it's not getting displayed. Thank you. Good afternoon, everyone. Thank you, sir, for the introduction. So, the previous two speakers have elaborately discussed the fundamentals of AI and the role of AI in retinal diseases such as diabetic retinopathy. I'll be taking it forward and we'll see how AI is helping us in diagnosis and management of ROP and ARMD. So the conventional approach, as we are discussing the conventional approach versus AI approach to treatment and management. So the conventional approach to ROP treatment or management is screening of at-risk infants by trained ophthalmologist as per schedule, and then treating once a treatable ROP develops. So the as per the Government of India guidelines, if we follow those guidelines, there are 2 lakh preterm infants born every year who need to be screened. So that's a huge number. And the number of trained ophthalmologists to screen those 2 lakh new infants every year is only 215 as per the Indian ROP Society registration data. So only 215 ROP ophthalmologists who are trained in screening and management of ROP are there. So it's only 1% of the total ophthalmologists in the country, and you can see the huge unmet need which is there. And it's not a one-time job. You have to screen every 1 or 2 weeks till the vascularization of the retina is complete or the ROP regresses. So it's not a one-time job. Multiple screenings have to be done for those many infants by a limited number of trained ophthalmologists. So, and coming to the treatment type, type 1 ROP needs treatment and the type 2 ROP needs watchful observation. And in type 1 ROP, we have zone 1 disease with plus and zone 2 disease with stage 2 or 3 with plus. Another important obstacle that comes here is the inter and intra-observer variability. So to some, this image, some will categorize as a zone 1 disease. To me, I'll categorize it as zone 2 posterior disease. So there is a variability which is there, and even a single person may categorize it as zone 1 or zone 2 posterior disease depending upon the field of view, depending on the quality of the image. So there is a huge variability. Again, it is also difficult sometimes to correctly pinpoint whether it is zone 2 posterior disease or zone 2 anterior disease. Based on a single image, it may be difficult. And this has treatment implications, because if there is a zone 2 posterior disease, then you may want to give anti-VEGF injection in those eyes, and if it is zone 2 anterior disease, then you may want to do laser in those eyes. And finally, you can always confuse between stage 2 and stage 3. And this also has practical implications, because stage 3 in zone 2 with plus will need laser therapy or anti-VEGF therapy, while stage 2 will need close observation. More subjective is the grading of plus disease in ROP. So earlier there was a 3-level grading that was suggested by ICROP2, that is no plus, pre-plus or plus disease. But now ICROP3 has come up with a more subjective continuum of spectrum, that is from 1 to 6, and it is from no plus to mild pre-plus to pre-plus to mild plus. So it has, the grading of plus disease has become more subjective. And if you are not having such photographs with you in the clinics, you may end up reporting it sometime as a mild plus or sometime as a plus disease. So the subjective variability is going to increase if you are using the ICROP3 classification. So how is AI helping in today's scenario in ROP? It is helping in the following domains: in detection of ROP, monitoring of the disease, and risk prediction. So how AI works, we already know. Aditya has already told. So with the database of images, fundus images, first a pre-processing is done. In case of ROP, it's the segmentation of the vessels which is done, and then features such as vessel diameter or the vessel tortuosity or the vessel length, and then the area of vascularization, area which is not vascularized, and rich tissue. These are the features that are looked, and then based on these features the disease is classified and you get the final outcome, whether it's a treatable ROP or non-treatable ROP. So the traditional machine learning tools such as there are certain tools which uses traditional machine learning, in which humans have to manually tell the machine that these are the features that you have to look, and based on those features the machine tells whether it is treatable or non-treatable ROP or what is the diagnosis. That is the traditional machine learning. So there are certain tools such as ROP tool or RISA and vessel map, but now the traditional machine learning has been slowly replaced by the deep learning or the convolutional neural network based approach, in which it will directly go from the step 1 to step 4 without humans telling the machine that these features are to be looked at. Such an example of a deep learning algorithm which is used in ROP is IROPDL, and it has been granted a breakthrough status by FDA in 2019, and it has been developed with funding from the National Institute of Health, and this has been used in multiple number of studies in the recent past, and this algorithm has a sensitivity and specificity of around 93 to 94%. So it is comparable to the human experts. Now, AI can also be used to monitor the disease progression and regression. So these algorithms, they come to a severity score. So a severity score can be calculated based on the analysis of the image, and that severity score can be later used to see whether the score is increasing or decreasing on follow-up. So that score can also help in picking up early recurrences of disease after treatment or failure of treatment. AI can also be used, it is being used to predict the risk of severe ROP developing in the children. So as early as 32 weeks post-menstrual age, you can use the fundus images, and without having any ROP, the computer will still detect some features, and using the deep learning algorithm, they tell what all babies are at high risk of developing treatment requiring ROP, and this can be predicted a month before developing the treatment requiring ROP. So there is a huge benefit that can be there, because once we know that these are the babies which are going to develop treatment requiring ROP, we can channelize our efforts more toward them, and those babies who are at low risk, we can maybe reduce the follow-up of those babies and maybe observe those babies at 2 or 3 weekly intervals. What are the future prospects? AI is nowadays it is looking at the perinatal management, appropriate management during the perinatal time, so that we can primarily prevent ROP rather than going to the secondary prevention. If we can manage the baby appropriately during the perinatal period, we can primarily prevent ROP. Then what is the risk of vascular arrest and vascular reactivation following anti-VEGF therapy? That is a huge dilemma these days, that when to treat such babies after anti-VEGF therapy, vascular arrest has occurred or reactivation is occurring in the form of plus or stage. So AI can help us in treating and following and treating those babies more better. And another important scope of AI is in ROP education. So there is a huge variability which is there in the features. So AI can correctly predict the findings, and it can help us teach better, because we ourselves will be more clear that okay, this is stage 2 rather than stage 3, this is pre-plus rather than plus disease, and so we'll be able to teach better. Coming to ARMD, so the again in ARMD the conventional approach is that you screen the elderly population which is at risk, and it should be done by a trained retina specialist as per the and then you grade the disease, and as per the grading you treat the disease. If we see the burden of disease in our country alone, there are more than 80 million people who are above the age of 60, and if we see the prevalence, data from the population studies, then the prevalence ranges from 1.4 to 1.4 to 30%. So a huge number of population is at risk of irreversible vision loss occurring due to late AMD. So that's why it is important to screen those patients timely and treat them timely. So here comes the role of AI in it, that AI can help us detect the disease in time, classify it, predict the risk of late AMD, and monitor it also. Because we don't have enough trained specialists in our country, we have only 2,000 retina specialists registered in our society. And if we see the population at risk, it will be roughly 20 to 30 million population. So that is a huge load which is there, and AI can definitely help in that. So AI can predict, can detect the ARMD, presence of ARMD, and stratify it based on usage of the fundus images, like we have discussed in ROP, that we can feed the images of no AMD or early AMD or intermediate AMD and late AMD, and then the machine will, through deep learning, come to a conclusion whether there is AMD, or what is the stage, what is the grade of AMD, and what is the risk of late AMD development. Not only the fundus pictures, AI is also nowadays using the OCT images. So based on the OCT images fed, AI can detect whether there is a, based on the segmentation which the machine does, it can detect drusen's, it can detect the volume of the drusen's, it can detect the atrophy of the outer retinal layers, the area of the geographic atrophy, presence of CNVM complex. The area of geographic atrophy can also be detected on the fundus autofluorescence images by AI. And even the recent studies have come up with the use of AI in interpretation of OCT angiography images, which till date it is sometimes very difficult to interpret those images, and we are still in the learning phase, and AI may help in better understanding of that software. So AI can also predict the development of late AMD, and the recent studies have told that along with the demographic features and genetic features, we can very well with 95% sensitivity and specificity pinpoint those patients who are going to develop late AMD and focus our efforts on them. AI can also detect the intraretinal and the subretinal fluid automatically, and this can be used for monitoring of the disease. It can pick up early recurrences, and then it can also help us know which patients are likely to respond better to therapy and which patients are unlikely to respond. What are the future prospects? That I've already told that the OCT angiography is nowadays it is being used, images are being used for the AI, by the AI algorithms, and newer algorithms are coming up, and they'll help us understand better the OCT angiography images, which currently we are not able to. Sometimes we miss the small vessel network, sometimes we are not able to differentiate between active and nascent CNVMs or scarred CNVMs. So AI will definitely help in understanding that better. AI will also help us to reach a treatment approach to anti-VEGF treatment. There are multiple anti-VEGF treatment options which are available, such as a PRN treatment or treat and extend and monthly treatment. So AI can analyze that data and can provide us with the results that, okay, this is the algorithm which may suit better in your subset of patients. So the challenges with AI are, as already been told, that we need to create a reference standard first, which is when 2 or 3 or maybe more experts, they sit down and then they analyze the images and then they label the images, and then this data is fed into the machine. So there can be an observer variability among the experts as well. So our reference standard itself may be at fault. Then we cannot generalize the results to all the population. Suppose based on the database of Caucasians, we cannot use the same algorithm in the Indian population. If a different camera system has been used, suppose if our algorithm is based on the RetCam machine images, we cannot implement it on the Trinetra Forus images. And if there is a field difference, if we are using a 120-degree field or a 60-degree field, again there will be issues with generalizability. So what can be done about this is we can validate the tool first on the target population and then only use it, rather than directly using it. Another issue is of explainability, because we cannot explain how deep learning is reaching from step 1 to step 4, from image analysis to directly to the conclusion without us telling it that these features have to be looked at. So there comes an issue of trust. So we do not usually trust things which are not explainable. So a way forward is that we can combine the deep learning algorithms with the traditional feature extraction, or that is the traditional machine learning algorithm. They both can be combined, and it has been seen that if you combine both, then your trust improves, your explainability improves, and even your sensitivity specificity improves. Medical legal issues are there, and one has to use an assistive technology first rather than an automatic technology, because even a 5% false negative rate can lead to missing some important cases, such as in ROP you cannot miss even a single case, and then the issue will come of the blame, that who will take the blame of missing those children, 5% of the children who are mislabeled with AI as well. Financial considerations, there are financial considerations in the initial phase, but in the long run, yes, it may be more cost effective. To summarize, AI-based automatic tools can provide substantial benefits in the diagnosis and management of ROP and ARMD, especially in our country. And till the time we have robust algorithms which get an federation approval, we should use AI as in the assistive mode rather than in the automatic mode. Thank you. Thank you for the patient hearing.
Thank you, Devesh. Your nice presentation. But only thing that whether in future, for ARMD treatment, whether the AI, what I have heard that it will diagnose the case and also give suggestions when to give the anti-VEGF, what will be the course, and when when the anti-VEGF effect is ceased, when the next anti-VEGF treatment should be given. These all are coming in protocol.
Yes, sir. So it is going to help us in making our treatment decisions. So it will tell us when to treat, when not to treat, how to treat, how frequent to treat. So all these will be the norm in the coming future.
Yes, yes.
Thank you.